Welcome everyone. We are going to get started. My name is Matt Martin, and I'm the director of the Behavioral Health Integration Echo Hub here at ASU. Thank you so much for coming. It's a beautiful day, at least here in Arizona on Friday, so thank you for joining us on, at least here it's beautiful. So we're going to start with introductions, and then we'll jump into the rest of our meeting today. So let's start with people who are not here at ASU. Let's see. So I'm going to be calling out what I see on my screen, which are phone numbers and ID names. So let's start with A. Rupp, that's A-R-U-P-P. If you will, please just unmute yourself and tell us your name and your institution. If you want to unmute yourself, there's a little microphone symbol icon in the bottom left-hand corner of your screen, and you can click on that to unmute yourself. We can come back to you. Let's go to...
Hi, can you hear me now?
Yes, who is this?
Oh, yeah, hi. My name is Dr. Ash Rupp, and I'm calling from Williams, Arizona at the Guidance Center.
Welcome. We're glad to have you, Ash. It looks like you're logged in through your phone and through your computer. Is that right?
That's right.
Okay, wonderful. Let's go to the next number, 203-465-9765. If you'll go ahead and unmute yourself and tell us your name and institution. Looks like you're on the phone, so you can unmute yourself by pressing *6. Or actually,
there we go. Hi, this is Matt Henninger. I'm actually calling from my car, but I'm at the University of Buffalo.
Okay, wonderful. Matt, glad to have you here. Okay, let's go to Ron O'Donnell.
Hi, this is Ron O'Donnell. I'm a clinical professor with ASU at the College Health Solutions. I'm a colleague of Matt's and looking forward to talking today. Thank you.
Welcome. Thanks, Ron. Let's go to, I think that was Michelle. Michelle, if you go ahead and introduce yourself. Oh, we can't hear you. You're muted.
You're right, I'm muted. Okay, now I'm not. Hi, this is Michelle. I'm with St. Elizabeth's Health Center. Many times you've done this and I haven't been able to participate. So.
Okay, we're so glad you're here today, Michelle. Thanks for coming.
Thank you.
Wonderful. Let's go to Mahalit.
Hi, my name is Mahalit. I'm an undergrad at Arizona State University, and I'm doing a summer internship with TechCo.
Great. And then let's go to Adrian, our director.
Hello, everyone. Adrian White. I'm the director of the ASU ECHO program and happy to join you guys today.
Okay, great. So for those of you who are new to ECHO, the whole purpose of ECHO is to create a community of learners and to connect them around a particular topic. So the topic for this group, this community, is behavioral health integration. And we specifically focus on the operational management side of integration. We talk about developing policies and guidelines, clinical workflow, hiring, recruiting, training behavioral health providers, as well as training medical staff and providers as well. So we don't focus specifically on patient care or talk about specific patient cases. We focus more on the actual implementation and sustainability of integrated care. So we meet every other Friday from 12 to 1 Pacific time or Arizona time. And we meet for just an hour. And the format that we follow is we first have just brief didactics where we have someone present on a particular topic from a training point of view. And then we move into a case presentation where we talk about a specific situation where someone is looking to improve a part of their clinic. One thing that I want to talk about before we go any further is about our website. So I'm going to share my screen using Zoom. And for those of you on the phone, I'll try to be as descriptive as possible. Okay, so this is our website. This is our fifth session today, so we've been meeting several times already, and this website has finally become more functional. The URL is chs.asu.edu/project-echo. And so you can learn more about this particular hub, behavioral health integration, as well as some of the other hubs that we're working on. There's information here about ECHO, about how to join the movement, and to meet members of our team. What I'm going to go to is the member portal here. So each of you has an opportunity to become a member of the ECHO. It's completely free. There's really nothing that you need to bring to the table except just your willingness to participate and learn and share your experience as well. So once you become a member, we can give you access to the website, and you can look at the past recorded sessions. In fact, that reminds me, I need to record this session. So let me turn that on.
Hey, Matt, I have it recording.
Oh, great. You're on the ball. Okay, let me share that website again. Okay, so here's the member portal. You can view upcoming sessions as well as archive sessions. So I'm going to go to archive sessions, and you can see what we've focused on in the past. So session 1 was looking at integrated care plans. Then we looked at measuring integration. And when you click on those, after signing in using your login, let's see, there we go. You should see the video of the recording and then any files. So we typically upload the slides from each session. So this is just a nice benefit for those who are members of the group. And again, you have to have that user ID to be able to log in. So after today, I'll send out an email and include this URL and some instructions about how to get access to information. And again, it's completely free. We want to make it as easy as possible to access it. Okay, so before I go any further, we have someone else that joined us, so I want to give them an opportunity to introduce themselves. So on my screen, I see the words Tara B. Tara, if you go ahead and introduce yourself, tell us your name and your institution. And it looks like you're muted right now, so you can unmute yourself. There you go. I'm not hearing anything yet, Tara. Can you hear us? Okay, we'll come back to you, but you can try to figure out the sound situation. We can't hear you. All right, so before we go into the didactics portion, any questions about our group, about ECHO hubs? All right, so I'm going to turn the time over to Ron O'Donnell, who's a clinical professor here at ASU, and I'll give him the floor. Thank you so much, Ron.
Great, thanks, Al. Thanks for inviting me, Matt. I was asked to present a topic related to healthcare management, so I chose quality and improvement, in particular using Lean and Six Sigma to help our behavioral health students in ASU Dr. Behavioral Health program to quickly master some basic Lean quality improvement skills and have immediate impact in clinical settings they're working in. So I'm going to cover really an overview of the kind of approach we use with our students, how we teach, what our expectations are, and the reasons we're doing this kind of work. So I'll go ahead and share my screen now with the slide set. I'll run through the slides pretty quickly, and then I'll stop for discussion afterwards. So the context is we typically have our students either while they're in the program as interns or if they're already working in clinical settings, primary care. The context of their work is they're in organizations that already have establish strategic plans. They already have often a quality assurance department, or they have different departments focusing on accreditation, different kind of metrics, either clinical and or utilization and cost metrics. And our students are launched into primary care, and they're there to support organizational goals. I'm going to argue that in most cases, the organizational goals relevant to integrated behavioral health are around achieving the quadruple aim. And we think that using Lean and Six Sigma tools are the best ways our students can have some immediate impact on clinical settings. The context is also our students are working in a team-based interprofessional environment where, while they have, maybe a quality improvement department already, when they're in the trenches in a primary care clinic, there's often no direct quality improvement process they can impact. And we want them to become leaders and actually impact and change processes as a behavioral health consultant in the primary care clinic. I think you're all familiar with the quadruple aim: improving the patient experience of care, improving outcomes or population health, reducing cost of care, and improving the provider experience being the most recent addition in terms of providers being burdened with great administrative burden, paperwork, insurance forms, feeling very pressured, and trying to help relieve that. So we think using quality improvement, in particular Lean, is a way of addressing all four components of the quadruple aim. I'll give some examples of that going forward. I also have to address value-based care, since that's increasingly important. Certainly, as we're moving from a fee-for-service to a value-based payment model, there's an increased focus on the equation, which is quality divided by cost of care, quality being measured by patient outcomes, the patient experience of care, and cost, of course, by the direct cost and indirect cost. Obviously, our goal in healthcare is to maximize quality and reduce cost of care. So interventions that are equally effective, the ones that are more efficient, are often the ones we want to choose to have our behavioral health consultants use in their primary care practice. The quality improvement model, I reference here the Institute for Healthcare Improvement, IHI. If you're not familiar with that organization, do visit the website. They have a tremendous amount of resources, including free online courses, resources. This is the book we use for our quality improvement course that I teach, called The Fundamentals of Healthcare Improvement. It's a great introduction to healthcare, very practical, very full of applied tools. And the basic model for improvement for the Institute of Healthcare Improvement is using the Plan, Do, Study, Act model, defining what we're trying to accomplish, how we're going to take actions to achieve the goals we want to achieve, and how can we measure and evaluate, are we being successful moving towards our goals. This is a very basic model, and the Lean and Six Sigma model really is compatible with this, often part of the quality improvement model, but separate in terms of the kind of tools that are used. And the Lean model in particular, I have two kind of graphics here embedded. The green squares going in a circle, that's the Lean, 5 parts of the Lean model: define value, map the value stream, establish flow, implement pull, try for perfection. The corresponding Six Sigma or DMAIC model is within that, the yellow arrows: define, measure, analyze, improve, and control. And just briefly, to make this make sense of this for a primary care clinical site, defining value, what's important to the organization, to the patient, to the clinician. The value stream is simply a map of a process you're trying to study. I'll give an example of that in a few minutes. Establish flow, trying to have a smooth flow from patient check-in to labs, to the physician evaluation, to a warm handoff to the behavioral health consultant, to the consultant's evaluation, assessment, and treatment plan. Pull is more difficult to describe. They talk about in Lean, push and pull. If you're pushing a patient through, you have maybe a consultant not prepared for any kind of patient in particular. They're suddenly getting patients who have diabetes and depression, or PTSD and alcoholism. If they aren't prepared for this different patient population, with having resources for assessing different patient subsets, with having treatment plan and interventions available, they're going to have backlog of patients pushing the system and not being able to move smoothly through it. A pull system is desired where you have everything prepared, whether it's screening, assessment, tools, handouts, smartphone app for the patient for a wide variety of problems. When the patient comes in, you can quickly offer them the tools that are tailored to their particular problems, and they move through the system very smoothly. That's what pull is. We want to try and achieve pull. Striving for perfection means we want to have our clinicians get into a routine of doing the same effective approach repeatedly with fewer errors, reduced waste. These are the goals of Lean, and DMAIC is a way of also just using the same kind of process approach to measuring change over time. I'm going to go over several, there are many tools in the Lean toolbox. I'm going to go over 4 we use in our program, in our course on quality improvement. The value stream map, run charts or control charts, a PDSA worksheet, and an A3 report. I'll mention at the outset, data visualization is increasingly important in healthcare. Rather than just having spreadsheets and rolls of numbers or statistical results from t-tests, you want to have visually represented data that can immediately be impactful, understandable by a team trying to work on a quality problem in healthcare. So the Lean tools are strongly focused on trying to use graphics to present data clearly, to present data over time, to present change and goals clearly and graphically with as little clutter as possible, ideally on one page. These are a few books that I've used. They're all interesting books. You want to try and get some help to improve your own ability to use data visualization. I recommend any or all of these books. This is an example of a value stream map. It's basically a process map. You're going to try and observe a process. In this case, this is a sample from a student assignment of a patient checking into a clinic and going through the assessment to see a behavioral consultant. I'm not going to bog down all different terms here. It would take too long for the time I have available today, but the bottom line is you're trying to measure from the patient walking into the clinic to checking into the receptionist to waiting to seeing the physician, seeing the nurse, having labs done, to seeing the behavioral consultant and being discharged, leaving the clinic, trying to evaluate and quantify every step in that process, identify what is a value-added service, especially from the patient's point of view. What do they value in terms of their time? They certainly value seeing the physician. They certainly value seeing the behavioral consultant. They don't value waiting in the waiting room 15, 20 minutes at a time. So you want to try and evaluate and document and measure all these components. And then there are ways to quantify. Quantification is very important. We want our students to be able to do studies pre and post, showing that, yes, here's our value stream map before the intervention. We implemented a change. Here are the metrics numbers after the intervention, showing we actually improved the process numerically and graphically. So these things in the bottom, I'm not going to define them here: cycle time, lead time, value adding ratio. These are all formulas available to help define different aspects of value-based care versus waste. You want to avoid waste, and they use an acronym, downtime, for waste. These are all kind of waste you might have in primary care. Defects, overproduction, waiting, of course, not utilizing the intellectual skill of the people available, inventory, motion, the patient moving through the clinic back and forth. These are all things you want to avoid. And when you do a value stream analysis, you can actually produce graphics that will show very clearly different ways of breaking down the current value-added activities that you want to have more of and the waste that you want to reduce. So you have an upper left-hand column. In this case, at the baseline, the red is non-value-added activities. 75% of the patient's time roughly is spent in non-value-added activity. You can break it down further into downtime. It's kind of hard to read when I transferred this pie chart, but you can basically see subdivisions of different kind of downtime. And the bar chart at the bottom is a similar graph showing for different aspects of the process: entering, having vitals taken, the RN interview, physician exam and checkout. What percentage of each of those processes and steps is value added versus non-value added? And you can see from this, red is not good. Big red bar graphs, you want to try and reduce those. So it's a nice way of graphically showing and sharing with the team, here's where we are now. What can we do to reduce this waste and increase value? And ultimately, back to provider burnout, providers are often equally frustrated by waste in the healthcare system. And what you're trying to do with our behavioral consultants is enlist everybody in the team, from the receptionist to the scheduling staff to the nurses, PAs, physicians, everybody involved to try and contribute to define the problem and contributing to possible solutions. It's a very empowering approach. And it's the way of having everybody become attuned to measuring the same process, both anecdotally in the course of their workflow in the day, but also trying to find ways to measure and label and graphically define their problems and solutions and monitor, are they effective in changing over time. The PDSA is a cycle of improvement, plan, do, study, act. This is a very detailed sample of a worksheet to document a PDSA. What's the aim? In this case, it's to decrease patient wait time. You want to have very clearly defined goals using SMART goals, a clear plan how to achieve those goals. Prediction, what will happen when we put our improvement in place? How are we going to measure the improvement? And after the plan's put in place, describe what was actually done, what the results of the study were, and next steps. I mentioned the PDSA being a cycle. It typically is something you'll repeat 2 or 3 cycles before you actually have a significant improvement that's maintained. You can then drop this and go on to the next problem you want to address. Control charts are another tool that are widely used in terms of the metrics using to evaluate change. Rather than just using a traditional, oh, we're going to do a t-test pre and post and see baseline versus 6-month follow-up, was our intervention improved? A control chart is a way of taking the same kind of metrics but measuring them more frequently, ideally, for example, weekly, and using that almost on a weekly real-time basis to evaluate where are we in terms of our measurement. Are we actually moving in the direction we want to move to improve our performance? There are different kind of formulas and rules for control charts and run charts to tell you if you're actually moving statistically significantly in the right direction. But it's a great way, again, of graphically representing and using in a team-based approach a moving measure of our performance from week to week. Again, you want to have basically a team being able to sit down weekly, looking at metrics, evaluating, here's our action, what are we doing? Is it having impact on metrics, yes or no? If it is, great, how can we keep on improving further? If it's not, what can we do differently in the next PDSA cycle to try and improve change? And last of all, this is an example of what's called an A3 chart. This looks kind of busy, but it's meant to be a way to graphically put together on one page all the key components of a quality improvement effort. It includes some of the things I just showed you right now, the problem statement. The current state is the value stream map for the current state. The problem analysis, what we call a root cause analysis. What are the causes of the problem? This is using a fishbone diagram. The future state is what we envision to be changed in the process after the improvement. The improvement plan is really what we're going to do and how we're going to measure our change. You can see a control chart again, trying to verify results and follow up. So again, the goal is to both document where you are in a change, quality improvement effort, to do it in a very simple one-page format. And once you train your team, these become second nature. They make much more sense. They can use them to really monitor and measure change in real time. So the goal of Lean and Six Sigma is to use these kind of tools to help identify and quantify problems. And of course, the process of change, I didn't cover that as much detail, but that really means all the things from brainstorming to identifying rapid improvement events to testing them out, trying things out, but very team-based. And these are tools that we were using to kind of demonstrate and show and quantify whether our improvement efforts are successful or not. I want to give you some examples to bring it home and make it more, I guess, real life for folks who are still grappling with this. Most of our students, by the way, come into this course with no experience in Lean, and our teaching approach is to have them actually try this using either case scenarios we built into the course, or ideally use it in their actual workplace with their supervisor permission. And most of our students are working full-time attending the program, and they do use these techniques in real time over this 8-week course. And student feedback is typically phenomenal. They find these easy to learn, highly beneficial, easy to share with their colleagues and teach their colleagues how to use them. We use an approach of tackling relatively easy to address problems. Don't tackle your most difficult, challenging problem first when you're trying these things out. Try and pick some low-hanging fruit and problems that are not too challenging. But I'll give an example here of using the Lean 5 components for a typical behavioral consultant. How do we define value? Certainly, we're often trying to improve screening and assessment for, say, depression, identifying more depressed patients might be not identified in the past. we're trying to identify how to rapidly get those patients access to a behavioral consultant. Rather than having medication as the first known line of treatment, we want to add behavioral interventions. That's part of the value equation for patients also. The value stream map, identifying behavioral conditions and problems. How's it done currently? Maybe currently, before you have a behavioral consultant, you're identifying these by having a physician just try and pick up on it briefly in a medical visit. You might have a referral out to a behavioral consultant in a specialty practice or mental health program, a drug and alcohol program outside the primary care clinic. Initial follow-up is often done in those remote settings. We want to try and improve that value stream from remote referrals off-site to referrals to behavioral consultant on-site. Establishing flow, of course, we're all familiar with the warm handoff, having the physician walk the patient right to a behavioral consultant and delivering the patient for immediate assessment, and having our behavioral consultants trained to do not 60-minute hour psychotherapy, but to doing brief interventions in primary care with very rapid assessment, screening, focused treatment plans, and short follow-up. And again, poll, if you have things like online health risk assessments, online screening, before the patient even walks in the door, they have done an HRA online where they have the nutrition, physical activity, depression all mapped out. And the behavioral consultant have access to that information when the patient walks in for a warm handoff. Have the behavioral consultant be able to say, here's some handouts for CBT, here's some mindfulness practice, here's some app you should use to help you address depression or diabetes. Having these things all ready to go for rapid assessment and intervention are part of good poll, having everything ready for the patient, irrespective of what kind of problem they have. We're increasingly facing multimorbidity, many different types of problems, medical, behavioral, lifestyle. It's critical to have our behavioral consultants prepared for that. And last of all, striving for perfection. We want to try to have our clinicians become better at using the same approach repeatedly, getting more efficient, more effective over time. That concludes my talk. So I'm going to stop sharing my screen, go back just to video view. That was a rapid fire approach. I know I want to give you a taste of Lean. If you have no experience, you can certainly go back to IHI. All these topics are covered in detail there. They have PDFs, diagrams, videos. I want to give you just a flavor of what we think is important for our students to be able to go into a healthcare setting and use these tools. And the last thing I'll say is we expect our students to become leaders, meaning if they're working in a primary care clinic, people are busy, right? They're already striving to get their job done daily. You have quality improvement departments can be giving them measures and metrics and reports from the senior leadership, executive dashboards. We want our students to be able to be fleet of foot and to do small studies in real time, maybe using an Excel spreadsheet and studying processes for 3, 4, 5 weeks, making improvements that are rapid, impacting improvements, while the overall organization, strategic plan, and quality improvement activities are still going forward simultaneously. So that's our goal, is give our students a role leading quality improvement, working in conjunction with the quality improvement department, but trying to do things independent on their own, and forming teams that become familiar with these approaches, become champions with the DBH or the behavioral consultant, and use them to improve processes and achieve the quadruple aim. I'll stop there and take any questions.
This is Matt. While people are thinking, I can ask a question, Ron. Thank you so much for that great presentation. For me, and I think many of us clinicians and managers are in a similar boat, QI training was not part of my background. It was traditional research. And so I've had to kind of learn on my own. The Institute for Healthcare Improvement, which you mentioned, IHI, offers fantastic free online training modules. You showed a book that piqued my interest. It was Executing Lean Improvement. I wrote down the title. I'm just curious if you've purchased that book and if you've looked through it and what you think about it.
Let me go back and share my screen for a second. I'll show it again. Hang on 1 second here. I'm glad you asked that question. I meant to actually highlight that, and I skipped over it in my goal to be efficient. Hang on 1 second. So this is the book here, Executing. You can't really see a title very clearly. It's not very good. It's Executing Lean Improvements by Dennis Delisle. I've taught the quality improvement course off and on for probably 6, 7 years in the DBH program. I've used many different books. This is my go-to book now. and it's very different from what you might get on the IHI website or other books on Lean and Six Sigma. Different in that it's very intensive, meaning it really throws a lot at you very quickly, but it's also full of amazing how to do it diagrams. It includes a CD with sample templates for using these different tools on your own, both blank templates to use on your own and sample templates already completed. It's easy to follow, and it really is heavily focused on using different metrics to define your quality problems and use visualization to show them in a team-based approach. And then it goes into more detail than I did about what are the actual steps for doing an improvement. How do you do rapid improvement, it's called? How do you bring together your team members? How do you assign roles to address a problem? How do you brainstorm? How do you use different techniques for problem solving? So this book is excellent because it's so detailed focused on the one level with, quantifying problems. It's so focused on visualization, and it's very practical. Our students can learn things very quickly, 8 weeks literally, and leave the course with competency. So if you want to learn Lean and Six Sigma, I recommend this book highly. IHI is great, but IHI is not quite as good about learning Lean. And last of all, you can certainly, take a Lean course, look for a Lean certification. They're often very expensive. You can also take a shortcut and just go literally on Groupon and find some very basic Lean courses there that are decent, for 25, 30 bucks or more. So you can, if you're really on a tight budget, those are good approaches to just force yourself to go through some learning experiences. You could spend thousands of dollars getting a green belt in Lean if you want to, but that's more if you want to focus on being an expert. For most of us who want to just learn some competencies while doing our job, not becoming, QI experts per se, this is a great text.
Wonderful. We have time for one question. If anyone wants to ask Ron any follow-up questions. Okay. Ron, thank you again very, very much.
My pleasure. I hope you become Lean champions out there, and our students really find this a real important part of their toolkit to achieve change in primary care. Thanks all.
Ron's slides will be available. We'll put them on the website, and really appreciate him putting those together. So we're going to shift now to our case presentation. This is going to be given by Adrian. This is a practice case presentation, and hopefully it'll give us a chance to talk about maybe using some of the ideas that Ron just presented, as well as drawing upon the experience and the knowledge that each of us brings to the group. So that the case presentation is something we try to do at every meeting. And once Adrian is done presenting it, the format that we follow is going to include a summary by me, just to make sure that we completely understand what she's asking of the group. And then we'll have time for clarifying questions. That's when you can ask any questions that will just help you better understand the case. And then after the clarifying questions, we're going to move to actual recommendations and suggestions. And each time we move through those steps, we're going to be asking for all of you to participate. So we have about 25 minutes left, so let me turn the time over to Adrian.
Great, thank you, Matt. And thank you, Dr. O'Donnell, for that great presentation. I have a feeling that I can maybe start utilizing some of those tools here in the problem that I have today. So I'm going to share my screen. Can everybody see that? I'm going to take no news as good news.
Yes, yes, we can see it.
Good. Perfect. All right, so today I'm actually presenting this on behalf of a colleague who was originally going to present this and wasn't able to make it. So I'm going to do my best. And I am admittedly a novice in the QI world. And so I know a little bit, I've taken a little bit of kind of introductory courses to some of the topics that Dr. O'Donnell spoke about in his presentation, but by no means consider myself an expert. So I would love to draw on the collective wisdom of the group here to kind of help me solve some of these problems that we have in this clinic here today. So the question that I have for the group in regards to this case is, how do we create a more efficient and effective workflow for our behavioral health provider that is currently within our clinic? So our target, what we're shooting for here, is to decrease our no-show rate to less than 20% on the behavioral health appointments that we have in our clinic, and to decrease the wait time to less than 5 business days for those behavioral health appointments. And we want to also do a better job of triaging and targeting patients with the most pressing behavioral health needs. I don't think we necessarily do a great job of that at this point in time. Where we're at now, so in September of 2018, we hired an LCSW, and at that time, we trained all clinical and operational staff in the consultant model. Right now, our behavioral health providers schedule includes 60-minute time slots for traditional counseling and 60-minute time slots for consultation. So both counseling and consultation appointments are scheduled for an hour with our patients. And then in February of 2019, we had a no-show rate for these appointments between 35 and 40%, which obviously isn't ideal. With thinking back to Dr. O'Donnell's, that might fit into the waste category. And our wait time is about 17 business days for an appointment to begin with. Here's a little kind of snapshot of what our schedule looks like from Monday through Friday. So you can see kind of a bounce back in between counseling and consultation appointments. Tuesdays and Thursdays, we only do counseling. There is no consultation appointment scheduled there. It's just, I guess, a little bit of background on the recent changes that we've made. We just implemented the SBIRT, but the behavioral health providers are not always available for the brief interventions. The whole behavioral health provider is now paneled with TRICARE and TriWest. We recently reduced the number of consultation slots, and billing staff are starting to generate reports specific to behavioral health services, but they're just starting on that work there. Some barriers that we have, our CFO is recommending that we cut out all consultation slots. Many of the physicians are referring patients that are not appropriate for behavioral health providers, and the scheduling and referral staff are managed by a billing manager, not necessarily a practice manager. So those are a few of the barriers that we're facing. So I know that was quick. So if you need me to go back to any slides to review, I'm happy to do that. And so for the cohort, the question I have is, or I guess, are there any questions that the cohort has now for me based off of this case presentation?
So before we move to questions, Adrian, if I can summarize.
Oh, yes. Sorry, yes, can you say, yeah.
So it sounds like the main goal is to redesign your clinic workflow to make it more efficient. It sounds like there have been some issues with no-show rate as well as a wait time to get in to actually see the behavioral health provider. If I remember correctly, the goal is to get it down to at least less than 20% of no-show rates, and then also reduce the number of business days for the waiting period to, I think, down to like 5 or 6. Some of the contextual factors include there have been a decrease in the number of consultation slots in the schedule. CFO is actually recommending getting rid of all consultation slots. It sounds like you are generating some reports to give you some data and some feedback on how well you're doing as a team. And let's see, I'm trying to remember some other factors. I think that's the gist of it, though. Did I summarize the overall pretty well?
Yeah. I think our biggest barrier is that we have these behavioral health providers somewhat integrated, but it feels like we have just putting them there isn't quite enough, and we're not utilizing them to their full potential. And there seems to be some systematic barriers that we have in our clinic that's preventing us from utilizing them to our full potential, but we're not quite sure how to work through those, and the best way to work through those and the proper steps to take, what to address first, that type of thing, to be able to utilize our behavioral health specialists to the best of their ability.
Okay, got it. Well, this is probably a scenario that happens in a lot of clinics, so hopefully we can have a discussion about it. So at this point, let's ask some clarifying questions. Think of anything else that you'd like to know about Adrian's clinic, about her situation. And if you're ready to ask a question, you can send it through chat, or you can just unmute yourself and go ahead with your question.
Adrian, I had a question. You mentioned that some physicians were referring patients that were inappropriate for behavioral health services. So what exactly do you mean by that?
Well, I think that our goal here is to triage the patients that are the most pressing behavioral health need. And it seems like the providers either are running out of time to get us there, or the behavioral health specialist isn't there to begin with, or isn't available when they're needed. And so integrating the provider's work and the behavioral health specialist work seems to be disjointed at this time.
Okay, got you.
Good question. Other clarifying questions from the group?
This is Michelle. I ate my lunch while you all were
Well done.
back online. Although I was here just eating. You were talking about them having 1 hour slots, and that there was like a 17 business day wait. Do they have any kind of warm handoff with the provider while they're waiting for that appointment, or is their initial contact with the provider that session 17 days off?
Yeah, so it is that we don't have a warm handoff point, and so they're scheduled directly with the behavioral health provider, and then they go directly to them. Yeah, does that answer your question?
I think so. What I'm gathering is that they, between when they are scheduled and when they actually have the appointment, there's no opportunity to meet the provider, and so their first appointment is the one that they're no showing for.
Correct. Yeah.
Okay.
Yeah.
Thank you.
Thank you. That's a good point.
Okay, while others are thinking about questions, one question I had was just about the size of this clinic. Adrian, how many medical providers are there, or how many active patients are on the rolls?
So that's a question I don't actually have off the top of my head. I mentioned I was presenting this case on behalf of a colleague, and to be honest, I'm not sure. I know that they have multiple clinics, and so I'm not sure the exact number of providers that they have throughout those clinics, and I don't know the patient body.
Okay.
My apologies.
That's okay. Let's see, before we go to a discussion about recommendations, other questions?
This is Matt, the other Matt. I had another quick question too. So with this clinic, are providers and behavioral health specialists, consultants, sort of meeting together to discuss patients, or is it kind of they're on their own separate silos? Are they meeting weekly to discuss these cases with these specific patients, maybe in non-adherent? Are there nursing involved, social work involved? What is the model really looking like? Yeah,
so right now we're trying to increase more communication and collaboration between the two, and I think there's probably more of that obviously on the consulting, during the consulting appointments, but we're really having a hard time getting those lined up and the providers available during those times. There's a lot less communication going on around the counseling appointments we have.
Because that makes me wonder if their medical providers are even aware of this kind of services that behavioral health specialists actually do, or are they just referring them because they present with just a mental health concern, but not really sure of the breadth of the services that they offer?
Yeah, I think that's true. And I think there's a little bit of variance among providers as well. I think some providers are probably more aware and better at utilizing them, and some providers are less so.
Great, thank you.
Okay, good questions. Let's go into recommendations. So we'll just start with anyone outside of ASU. Any suggestions or recommendations you have for Adrienne? Again, her goal is to decrease the wait time, decrease the no-show rate, and just in general have a better workflow for her integrated care service.
This is Michelle again, and my suggestion goes with my question. And that is, I was wondering if there was some way of working in a more direct contact with the behavioral health consultant when they're being referred by the medical provider, as a way of reducing the no-show rate.
Can you explain that just a little more to me? So the handoff, the handoff comes from the provider to the behavioral health consultant. And so what are you suggesting in that interim time?
Well, I'm suggesting that what I wasn't clear on, and maybe I still haven't quite got the clarity, it sounds like that the provider identifies that a patient needs a behavioral health consultant, but that the patient doesn't immediately meet the behavioral health consultant with the warm handoff model. And so if there was some way to have that immediate meeting happen, then that does tend to reduce the no-show rate.
Yeah, and I think that happens more during our consulting hours than our counseling hours, for sure.
Okay, so then what I'm wondering is if there's some way of kind of changing the schedule, like if the behavioral health consultants would be open to doing less than 60-minute sessions, even if they were 45-minute sessions, so that then they could have a part of each hour where they could be available for warm handoffs. They could do 30-minute sessions, then they could do that as well, but some more immediate contact, brief contact.
Yeah, it would be interesting to look at to see, we didn't do this, but that brings up a good point. And it'd be interesting to see if we have more no-shows during the consulting hours or during the counseling. Yeah. All right. Thank you.
Great. Other recommendations?
I don't have a recommendation, but I did have a question. What effects do you think there would be if you completely took out consultation? You said completely took out consultation meetings, right?
Given the recommendation that was just provided, I don't know. It'd be interesting to see. I have a feeling now that I should go back and look at the data of the no-shows versus the consulting and the counseling, and I feel like we probably have a higher no-show rate during the counseling visits, and the more integrated time with the consulting, we might have a better adherence rate. So taking out the consulting, I don't know if would be beneficial. It might be more beneficial the other way around. Although my CFO is promoting the opposite. Yeah. Are there, I guess now that I'm kind of thinking through this, are there is there other organizations out there that do a better job of billing during the consulting hours? Because I think that's part of the push I'm getting from the CFO here is that we're not billing during the consulting hours, but we're billing during the counseling hours. Are there any recommendations around that?
This is Michelle again, and I can tell you that we bill for everything. Yeah, if it's a consulting, we bill it as a session. I mean, it is.
Right.
So.
Sorry, I'm rapidly writing notes here to pass.
Sure, no problem.
All right.
Are there other thoughts about that, about billing patients or payers for that consultation time, that warm handoff time? Anyone else have experience with that?
Are patients aware that they could be billed for that warm handoff for that consultation time? And that's something to think about. I don't know if you know about that specifically, but.
If you're asking me, when I realized after I said that I should have modified what I said and added a little bit more detail. For the ones who are sliding fee scale, for the warm handoff, we usually don't bill them because it comes sort of wrapped into what they've paid for their service that day. But if it is for a Medicaid patient, the rules do allow us to bill for that service, and so we do. That's allowable here in Arizona. I don't know if it's allowable in Colorado.
Okay.
Yes, so I have some thoughts that I can share. One is about billing patients. There are some places that, like Michelle's clinic, that do bill patients for all the services, and they have found, this has been my experience and what I've heard from colleagues, is that the patients are okay with that, and they actually expect it. They expect to be billed for the services that they receive. For some places, depending on the state and in certain payment models, some clinics will, I'm trying to remember the right wording for it, they will waive that first fee, or they will eat it, so to speak, and not pass it along to the patient. So that depends on the clinic and what is allowed in the state. Going back to the question about how to build a better workflow, it sounds like this is a great opportunity for a quality improvement project. And this comes back to Ron's presentation, that what I would recommend is putting together a great team that can look at the workflow. So this could include the practice manager, the billing manager. It could include clinical staff, like some of the clinicians and the nursing staff, to talk about how do we design a workflow that identifies the right patients coming in at the right time for the right provider. And that may have to include a conversation about what model of integrated care do we want to have. Do we want to have a more traditional mental health model that's co-located into the practice, where our behavioral health provider is seeing patients for 60 minutes. There are some clinics where they do that successfully. However, sometimes the ramifications of that is that it does restrict access for other patients. And if the referrals are not appropriate, like it sounds like maybe in your case, Adrian, that it can lead to a higher than usual no-show rate. So this team can sit down and talk about what kind of model do we want? Do we want that more traditional model, or do we want a briefer treatment model where patients can come in for 20, 30 minutes, and there's a lot more flexibility in the schedule. Once the team decides what model they want, they can start to work on an implementation plan to redesign that. And that will typically include a timeline as well as a checklist for how it's going to look, and at what point are we going to change certain things. It'll likely require a change in the scheduling strategy, as well as what patients are we going to target. Are is this service going to be available to everyone, or are we going to target those that have chronic conditions, or maybe have multiple chronic conditions, or have certain benchmarks? Those are all decisions that can be made by the team and then implemented together as a team as well. But if the team decides, no, we kind of want to make the traditional model still work, then there are lots of strategies to make that work as well, including the warm handoffs, like Michelle mentioned. Sometimes, at least in my experience, that medical providers will refer patients who are not appropriate just as a way of moving on to their next patient and relieving that pressure of having to provide treatment to the patient in that moment. So lots of strategies to make the traditional model work, but I think it really comes down to just to deciding what kind of integrated care do we want to provide.
Mm-hmm. Yeah, thanks, Matt. Yeah, there's some comments on the chat here too that kind of allude to some things that you were talking about, and I think that, you know, after talking this through, some of our major barriers here is that we do have a mix of models happening, and if we can go back and kind of lay out the different processes for each of the models, maybe overlay that with a little bit of data to support one versus the other, might be able to shift some of the leadership in their ideas of moving this towards a better model that is better for our patients, or at least one model. And how do you guys feel about, you know, if we do all that, there's supporting evidence here that we should move maybe to the consultation model here. Some of the cultural barriers of getting that done, you know, is it best in your experience to just kind of do like a cut and start with with one model, or, you know, have maybe a pilot day where it's okay, on this day we're gonna switch to this model and see how it works? What are your thoughts on that?
I can jump in quickly. Just two things. One, I would pick some kind of process mapping tool. There are many out there. The value stream map may be too complicated, but you can just go online and find a good process, you know, mapping tool, so you can really map out your current process. And in terms of, you know, team building, you know, back to Matt's idea, that's great for a comprehensive plan, but in reality, it's often difficult to get everybody to buy in. You might want to start small, just kind of talking to people one at a time, finding who really is interested in this kind of approach, finding some champions. And if you can get 3 or 4 champions to start talking about how to make that group do a small improvement project, a pilot project, and spread that to other team members. And the same thing for your idea. If you show evidence about needing to have the consultant model put in place, that's great. But I think, again, doing a pilot is often my preference, only because people are so already overburdened and stressed out. Any kind of change is more work, and you can get resistance. And if you find a small group that's enthusiastic and motivated and they're successful, and you can actually show success both in terms of metrics and their enthusiasm and happiness, that can be contagious and lead to more likely reception and decreased resistance for the entire team down the road. If your team is already on board and they're already enthusiastic, that's great. But in my experience, that's not the case typically. So it needs a good analysis on your part and do what you can do to build success. I mean, don't try and take on too much. Do something you know will be successful and start small rather than trying to do too much and failing spectacularly and losing the opportunity entirely.
Okay. Thank you.
All right, we will have to leave it there. That's a great final comment. Adrian, thank you so much for presenting that case.
Yes, I thank you all for your comments and your insight.
Good luck.
Turn around and thank you.
Thank you everyone for joining today. The next time we're going to meet is in 2 weeks. That's on May 31st, Friday from 12 to 1. And if you have any colleagues that are interested in joining our group, please let them know. Just send us their email address, or you can send the meeting information straight to them. I hope everyone has a great weekend, and we'll see you in 2 weeks. Thank you. Bye-bye.